Hi, I'm Dr. Krista Burns, founder of the American Posture Institute and your host for the Pain Summit. The purpose of the Pain Summit is to provide healthcare professionals with practical solutions to help your patients overcome chronic pain. I'm honored to welcome Nick Moss, functional neurology practitioner. Nick, please take it away sharing your protocol to help patients overcome chronic pain.
Most of us know that if we're treating pain in general, we know the research has come a long way. We're not just treating the tissues. I think most of us are aware of that. We are generally going to be treating all levels of the nervous system. And when I say treatment, I use that word loosely. I think the approach that I have to working with chronic pain, having suffered it extensively myself for probably over a decade, chronic right hip, lower back pain, using a combination of bottom-up, movement-based, musculoskeletal sort of work, and then top-down work on these threat reflexes in the nervous system. And then also many years treating it is the more I've gone to a brain-first approach, the better results I've got in my practice. And just sort of settled into the client's or the patient's nervous system is always functional, even though we use the term dysfunctional. Potentially that can be nociceptive language. Most people know what nociceptive language is. You can get the nocebo effect. We say, oh, that's a dysfunction, or that's this, or, people, our patients and sufferers who are already in a state of threat, heightened threat, the longer they've been in a state of chronic pain, the more levels of threat they have. When we use those words, that can have a big effect. So I come with the viewpoint that their system knows exactly what it's doing. It has its own hidden logic. We may not understand it consciously just yet because maybe the research hasn't caught up. We do know a lot about the nervous system. We know about the brain. The brain is finite, right? And we are just discovering new connections and things all the time. However, the mind, the individual mind that we're dealing with is very complex. The mind is not the brain. And so it's that individual's journey through life, which is going to determine how their receptors, their nerves, their spinal cord, the brainstem, the cerebellum, the cortex, all these pain circuits here. I shouldn't say pain circuits, let's say threat circuits. We know there are no pain pathways per se, but there are threat pathways, and they are called nociceptive pathways, and they come from the brainstem, go into the thalamus, insula, anterior cingulate, prefrontal cortex has a role in that as well. And there's this constant feedback in the brain, and then from all the different levels here. And I think being able to have that viewpoint when you look at pain, it gives you a great advantage, because instead of looking at the level of receptors, which is the tissues, the muscles, the joints, they're still important because they still send information all the way back up here and into these circuits here, but they're just one aspect, right? So how do we know whether coming in at the cortex level, cerebellum level, receptor level, how do we know which level to come in at? And that's what the question I was asking since getting into functional neurology over 12 years ago, and now teaching my own approach, is how do we reliably know where we are and where to start? Okay. That is a bit of a game changer. And that's what I've sort of structured my approach about. And that's why myself, I had some good results, and many of my students, no matter the experience level, because of our system, have seen as good results as I have, because it's not about the talent level, it's about understanding. We don't want to just teach techniques, because techniques can be learnt, but it's the way you think in the clinic which determines your success. And I think you know this if you're watching this. Okay, so our protocol for pain in general would say chronic pain. And a lot of this stuff would be probably similar stuff that you're doing. There may be some slight differences. This is our general sequence. We will look at a detailed clinical history. As we know, the details are there. The history should not be a mystery. Okay, we pay special attention to previous injuries. It seems obvious, but sometimes we overlook it. How do we know, is that injury, is it still sending signals, nociceptive signals from the injury up to the brain? If so, then there's going to be dysfunction, dare I use that word, within the system. Past trauma, yep, conscious or unconscious, childhood development. This will be more relevant in some cases than others. We know when you just look at someone move, you can see a lot about, when you just ask someone, just, hey, go for a walk, walk down the hallway and back in your clinic, you can tell a lot about how their sensory system is perceiving space. And the more disjointed and, compressed or uncoordinated, we know there's potentially childhood development layers, potentially recurrent signals coming from those previous injuries, which is shutting down certain unconscious movement function as well. So we will go from there. The history, what happened before, what happened. I've never been the same since type questions. And we want to establish what is their goal. How do you want to feel when you walk out that door? That's all I say to people. Okay, got all this information, great, go. How do you want to feel when you walk out that door? I want to feel this. Okay, and if you feel that, how would that make you feel, etc. So there's the dream. Now it's our job to work. Okay, that's your conscious goal. That's what you want, and you want that because you want to play with the kids or whatever it is, or go for a marathon or whatever it is. Now let's assess your nervous system. So we're going to globally assess the nervous system for these threat reflexes. So the primitive reflexes, the cranial nerves, and is the previous injury playing into their dysfunction? Okay, we have a look at that. Then we're going to do a local assessment of where the pain is, where the restriction is, like you would normally do, range of motion. We might test some muscles. We might do some palpation of different tissues, motion palpation, things like that, spine, whatever it is. Okay, so we've got the global, the local. Then we will, okay, let's start working. We'll bring you on the table and we're going to start downregulating that sympathetic response, getting into a parasympathetic state. We do a few manual approaches for that. Get their phrenic nerve firing so they're now breathing properly. Already feeling better, we move some lymph, okay, setting them up to be able to receive the neurological, structural, or emotional corrections. And we will correct their primary or priority pathways, primitive reflexes, cranial nerves, previous injury. That might be, can only do one or two of those in the first session. And then next session, they'll come back, we'll recess and we'll recheck our work. And then we'll correct what didn't hold and what we haven't done yet. So in the session as well, we'll correct something, we'll reassess it, we'll bulletproof as much as we can that correction. For instance, pelvic instability, causing back pain. Okay, there's a bunch of muscles that aren't firing on their pelvis, in and around their pelvis. We correct them. Okay, on the table, they're feeling great. Jump up, jump down, walk around the room, come back, retest the same structures. Oh, okay. So basically, as soon as I leave the table, it's going to come back. So we need to correct from that point as well until they can basically get up, walk off the table, jump up and down, run maybe. That's how we look at bulletproofing. So we'll take a slower approach because we're trying to be really thorough with each correction that we're doing as opposed to doing heaps of things. We can still gather a lot of information, but the actual corrections are quite minimal. So once we've done that, in each session, we may, if need be, so for instance, if cranial nerves come up or there's a specific joint area that needs to be stabilized, precise, graded, and measured drills at the level of tolerance. For instance, with ocular drills, like it's pretty big in functional neurology, like maybe they have a hypoconvergence on their right eye. We know that's going to affect their midbrain and their flexor control through their, in particular, their shoulder muscles, which is going to affect gait, which, potentially can bring things back. But if we drive convergence and there's something that's underneath that's driving the hyperconvergence of their eye, the eye is not tracking towards midline, then doing the convergence is potentially going to irritate things. And or maybe you've corrected that and you need to test how many reps they can tolerate. Is it one? Is it two? Sometimes it's just one. And they're doing that one rep maybe every hour of the day for 1 week, and then we increase it 2 reps for the next week, every hour of the day, and then 3. And around that time, the system just starts to lock in, and then you've trained that nerve or you've trained that pathway. And so slow is smooth, smooth is fast. It's going back to the army days. I find that's, yeah, less is more, graded, take your time, do your correction, go back, recheck, bulletproof, check your work from the previous session, and just keep rolling through the many pathways that we have to look at. So we generally have that global approach first, and then a lot of the times, maybe 50% of the time, we don't have to do anything at the local area. But other times, yep, there's still something going on locally or the local areas. Now the corrections we do in those local areas are going to work much better. They're going to hold because we've gone from this global approach inwards. Hope that makes sense. And there's a case study of one of my students which demonstrates this perfectly. So Alyssa, she's come from a Pilates and manual therapy background, scar tissue therapist as well. And she got this amazing testimonial on her Instagram, which I saw, which is basically 6 years of chronic pain, 2 sessions, 95% improvement in pain and range of motion. Blah, blah, blah. Okay, so it talks about the case there, which you can read through. Basically just gives her a massive wrap. And at the time of these results, Alyssa had only been using this approach for less than 2 months. She'd done other trainings before. She was already a good practitioner, but this just took it to the next level. And I said, yes, okay. I said, I saw this story and I was like, hang on, that's awesome. What did you do? And she said she only corrected the foundational pathways, the primitive reflexes and cranials. At that point, she hadn't really done any local work yet in those 2 sessions. Session 1, primitive reflexes, session 2, cranial nerves. And that shows you there's the top-down influence of pain in this chronic pain. She had not treated the site of injury, so that goes back to she was probably correcting this here. Yeah, so that was pretty cool. And I mean, it took me a while to put this system together, but that was like, okay, I'm glad I structured it that way because it seems to be, and this is not this, I've seen this many times, many other people have seen the same thing. And then sometimes, yeah, there's trickier cases. It doesn't matter. We just flow through our system. And every now and then, I said there's that 5% that you can't get and you need to refer on. Maybe it's a structural issue or whatever it is. Or maybe there's a particular type of practitioner or nutritional approach that they need to take as well. Happy to do that as well. But let's look at those high level systems first. Let the healing integration power, the self-organizing power of the nervous system do the heavy lifting for us as practitioners so we can serve at a higher level, have more capacity to think and hold space for our clients as they go through this stuff. And yeah, clinic will probably be a little bit easier, not so hectic. Okay. What you can expect from this approach as a practitioner is obviously better client outcomes with less effort. That's what we're going for. And that's what's happening. And we're always updating and evolving and trying to make and improve things as we go along. A clearer understanding of your in clinical processing. So we clear brain space for you. It doesn't take away anything that you've already learned. Maybe you'll understand what you've already learned in a deeper way. It's a structured but loose system. It's not like a recipe like step 1, step 2. There is a framework because obviously that narrows your thinking. It's like, well, what do I do if this person comes in? There's a structured framework, but it's loose depending on who you're working with, etc. So it gives you a framework to understand and then a system to use to correct anything that comes in through the door or know when you can't. Okay. Increase referrals, of course, because results will get better. High level understanding of practical neurology and integrative approaches. So as you know, Krista, when you have an understanding of neurology, you see things differently and you can understand and comprehend things at a deeper level and understand things previously that you're like, oh, now that makes sense. Okay, that's cool. So that's what we aim to do as well, arm you with that knowledge. Much more flow in your clinic. That's a lot of the results or the feedback I get back. I just feel like it's easier. Yeah, cool, great. That's what I felt too. Okay. Here are some clinical pearls if you want me to share them about what I've seen with working with chronic pain over the years. Some of you might know this stuff. It may be self-evident. If so, great. I'm reminding you of it again. I'm always trying to seek simplicity as I keep continuing to practice. So clinical pills, when it relates to like chronic pain, sensory-based approach is try to find the patient's nervous system goals instead of their conscious goals. So conscious goal is, okay, how do you want to feel when you walk out that door? I want to feel this, pain-free. How would you feel when you're pain-free? What's the emotion? That's their conscious goal. Great. Our job is to now go, why are they not pain-free and feeling happy in their body or whatever it is they said, or able to run? Okay. Why are they not? The nervous system knows. So the nervous system's goals in that moment usually is perceiving threat. So why is it perceiving threat? What's its goals? It's a threat. Let's work out where in the system it's at its highest levels of threat, previous injury, sensory system, etc. And then if we can marry nervous system goals with conscious goals, we will have results. They will be happy because they'll see, yep, we're heading in the right direction. In my experience, the fastest way with the chronic pain is the sensory first approach, which is what we've been talking about. Chronic pain is a sensory processing disorder. Regulating your patient's autonomic system, as we talked about in one of the steps, before driving any input, especially if they are sensitive. The more sensitive they are in those initial sessions, the more you want to focus on this before you start driving input into the system, whether that's hands-on or brain drills or whatever it is. Take your time with this because it will pay off in the end. Move at this, again, similar thing, move at the speed or the load tolerance of their unique neurology, their nervous system. We don't know until we test. It's just a guess otherwise. We have multi ways of testing: observation, palpation, range of motion, muscle testing. We use a lot in our approach as well. And so we combine all those things together, and then we can take steps to move at the speed of their level of tolerance. Another key one that we really need to look at is, what is their internal narrative about their symptoms? How do they perceive pain? How do they perceive suffering? Is there a family lineage of it? Is it around them? What's their environment like? What are they saying to themselves? Because without that changing in a more open, expansive way, it's hard for them to really heal for the long term. So there is definitely a psychological aspect. The more long term it goes, the more they build that narrative. And I call it like they build their psychology around their survival persona. What's a survival persona? It's like, well, I'm just scared. Like you're always in that, you're always stressed, you're always been triggered. And maybe there was stuff that happened in childhood for them. Maybe there was abuse and trauma. We know this is very common. Unfortunately, it's very common. We see this a lot. Maybe they've been in this threat response their whole life, but they've mistaken that threat response as their personality. And so there needs to be a point, and this is where you may need to work with a psychologist or someone in that area if you're not comfortable with that. But that's a really, really important part, because they need to build the mental models and frameworks to be without pain, to not be in a suffering state. Doesn't matter, because if they're in that suffering mental state, you could be the best practitioner in the world. You're not going to get the long-term results. I think that makes sense. So if you don't already have those soft skills, which you can develop just by being a practitioner over a long period of time, and you may need to do specific training in that. We talk about this stuff in our mastery work, but also, who's a good mental health practitioner or professional in your area who knows how to work through those mental models, or a coach, a good, performance coach or someone like that that's sensitive enough to work with people suffering with chronic pain. Okay, so there's some of my clinical pearls. And then how you can implement this approach. I do have a free training. If you just go to my Instagram and you just DM NeuroPro, it'll get sent to you. I'll send it to you, or you can click on the link there. There's a little bit of information about this approach. I can send, for people who watch this, practitioners, I can send you for free a deeper training. It's another hour and a half training on chronic pain for free. I got the Move Out of Pain mini course. It's a cheap course. Depending on what type of movement practitioner, maybe you don't need that. But if you're not, and you're wanting something that you can potentially give your clients, patients, to help them in between sessions, this is actually a really good course, as long as they're not too top-down oriented and they're not too chronic. This is a really good way of getting people out of chronic pain. I've had veterans in 10 or 20 years of chronic pain do this program within 2 or 3 days. They're like, I can walk, and it's like, cool. So again, that's not for everyone, but that's a little resource there if you want it. And then if you want to take the leap, you can sign up to one of our programs. Just start chatting to me on Instagram, or once you get through these pipelines here, you'll start to get in more contact with me anyway. So hopefully that was helpful. If you're working with chronic pain, keep learning, keep evolving, keep developing those soft skills. And yeah, sensory first, I think, is a great way to go. Doesn't mean you need to know everything about the neurology or anything like that. It just means looking at it through that perspective. Sensory first, pain equals they're in a threat response. I think that can go a long way to helping your patients and clients. So thank you for that.
Absolutely. Yeah, thank you, Nick. And I want to encourage everybody to learn more by following up to get a hold of those great resources and following your trainings that you do. And I love this sensory first approach, especially when it comes to working with patients who have complex chronic pain conditions. And as we wrap up another great session today on the Pain Summit, I'd like to acknowledge Nick for his excellent work. I'm Dr. Krista, your host of the Pain Summit. Be sure to check out the Advanced Chronic Pain Solutions course held exclusively for healthcare professionals to help your patients overcome chronic pain.